Yes, we can.
Sudhir, yeah. So from Aslan source, you guys can hear right properly? Okay, so hello everyone, welcome to our first mock paper session for surgery, ERPM. So my name is Avinash, and we'll be discussing some questions that we have compiled using past final MBBS questions from the local universities as well as the ERPM past questions, and we have combined them and made a paper. Okay. So our goal is to finish about 10 papers before your theory exam. So the important thing is I don't want to waste your time. So in these 2 hours, I make sure that we can go finish that, try to finish the entire paper, while also making sure to explain the concepts in detail as well, so because it will be useful not only for your theory but for your vivas as well, for your skis rather this time. So yeah, I hope some of you at least have done the paper. So and just this all of this will be much more easy if it's an interactive session. So since we are starting, it's completely fine to make mistakes and it's completely fine to actually may not be sure of the exact answer. That's completely, but make sure to talk because this will be useful when you're going to your OSCE also. Okay. So we will not just discuss why the question is right, why this answer is correct, but we will discuss why the other answers are wrong as well. So the mistake that a lot of people make during the preparation for this written exam is that they assume that if they just memorize the papers, the answers to the papers, that they can get. It's not like that. Okay. So you have to know exactly why the other answers are wrong. So then you will get a good understanding of every concept. So the important thing is to not just put random facts into your mind, but to get into your head the concepts. Then even when you have a scenario that you might not have encountered before, using that knowledge, you can at least come up with an answer. That is what I'm trying to get you guys to do. Okay. So okay. So there, shall we start the paper then?
Yeah, we'll start.
Yeah. So I'm sharing my screen. Can you guys see it? You guys also should talk. Okay.
Yes, we can.
Mhm. Okay. Uh, so the first question is 67-year-old man undergoes an elective right hemicolectomy for carcinoma of the colon. On the second post-operative day, he becomes restless and confused. His pulse is 120 beats per minute, blood pressure is 90 by 60 millimeter mercury, respiratory rate 28 breaths per minute, urine output is only 15 ml an hour. Central venous pressure is very low. What is the most likely cause for this patient's deterioration? Okay, so this is an SBA about perioperative care. So when you're met with an SBA like this, it's a good habit to always underline quickly the important parts of this SBA. So one thing is a 67-year-old man, an elderly male. Other thing is an elective right hemicolectomy. So he has undergone a bowel resection, which was elective, not an emergency, and elective. And the next important thing is on the second post-operative day two, he becomes restless and confused. Then pulse rate is 122, blood pressure is 90 by 60, bit on the low side. So he's tachycardic, hypotensive, tachypneic as well, respiratory rate is elevated. And the urine output is only 15 ml per hour. So it's also decreased. So what would you expect the normal urine output to be? What is the minimum that we usually consider? I think it's better if you guys can turn on your cameras also. We need this to be an interactive session. Otherwise, there's no point in me just telling the answers and you guys just writing it down. So, did any of you do the paper? At least just attempt a few questions at least. Hello. කෙනෙක් හරි කතා කරන්න ඕනේ නැත්තම් වැඩක් නැහැ. So I'll point out someone. Taraka, no one. Can you hear me? Sure. Audio on.
Yeah, I can hear you.
Okay. Did you attempt this paper?
Yeah, I did the full paper.
Okay, very good. Okay, so Taraka, so what is the initial impression you get about this patient? What do you feel?
The patient is unstable in post-operative day 2.
Very good. You have recognized that he's unstable. Yeah. So now, what the result? I mean, the main options we have are myocardial infarction, pulmonary embolism, hypovolemia, sepsis, and anastomotic leak. So from these five, what do you think is the answer?
I think most probably hypovolemia.
Hypovolemia. Okay. Why do you think it's hypovolemia?
Yes, blood pressure is low and the heart rate is increased for compensation, and
Okay.
respiratory rate also increase, and urine output
Mhm.
decrease due to renal ischemia in
Reduced renal perfusion.
Yeah.
Hmm.
I thought that pulmonary embolism is not the answer because not acute chest pain and X-ray features are not there.
Yeah. And it's a bit too early to get a pulmonary embolism, no?
Yeah.
So on post-operative day 2. So
Yeah.
usually pulmonary embolism you might see towards day 5 to 7 or even after 7. It's a bit late. It's a bit of a delayed process. So for pulmonary embolism to occur in a patient who has undergone a surgery, they will have to get a deep vein thrombosis first,
Yes.
and then that clot will dislodge and embolize and then go into the pulmonary arteries. So that process takes some time. This is the second post-operative day. Anyway, patients, when they are post-operative, they will require a little bit more fluids than normal human. Normal person, this patient will require, because they can have intraoperative blood loss, they can have third space loss, they can lose a lot of fluids while the patient is undergoing surgery and in the immediate post-operative period.
Yeah.
So it's from all of these in the information that has been given, I agree with you. I think the diagnosis is hypovolemia. So I think so. What would be he's dehydrated. What would be the grade of dehydration, you think?
Dehydrate.
So probably severe, no? Because he's displaying some neurological changes also, and he's restless and confused.
Yeah.
So he's probably in severe dehydration, probably due to now this. Immediately after a bowel surgery, you will not start them on a very large amount of oral fluids also. So probably he might not have been kept on his maintenance IV fluid requirement.
Yeah.
So he not being given the enough IV fluids, and that has led him to become hypovolemic. So now, why do you not think it's a myocardial infarction?
It's
we know why it's not pulmonary embolism. It's clear to everyone.
Yeah. There's no information about acute chest pain and diaparesis and other features of MI.
Yeah.
And ECG features also not there.
Yes. Any other small specifically from the information that has been given, there are two things that would make a MI a bit unlike. So central venous pressure is very low. So usually central venous pressure will reflect the fluid status of the patient with regard to the blood that is in the right atrium. Okay. So when there is an MI or if there is any problem in myocardial contractility, that means the heart cannot pump out the blood and send it around the body, but the myocardial filling will be adequate. You understand? So the central venous pressure will not be low; it will be either normal or elevated. The blood that is in the heart is not being able to be pumped out. You understand?
Yeah.
So because of that ineffective because of that ineffective contractility, the central venous pressure will either be normal or elevated. So, an acute myocardial infarction will not usually affect the urine output like this. So we need a minimal of about 0.5 ml per kg per hour. So roughly it's about at least 30 to 40 ml per hour, at least. So an acute MI will not cause this. Okay, why is it not sepsis?
I exclude the sepsis because no capillary refilling time is not less and not mentioned. Um, uh, Not mentioned about lactate level.
Hmm.
In sepsis, lactate level is more than 2.
Hmm.
And as a reminder, not sure.
Hmm. Yeah, you're right about the lactate level. I agree with you, but then capillary refilling time is not a very useful marker of sepsis in itself. In sepsis, what happens? There is peripheral vasodilation. So because
Yeah.
when there is peripheral vasodilation, you get actually bounding pulses, and basically your peripheries will be warm and red in sepsis because of the inflammatory metabolites which are released during sepsis, during our body's response to this microorganism. It will cause generalized vasodilation. That is, so it's a distributive type of shock. Now we have our types of shock. Now we have hypovolemic shock, cardiogenic shock, obstructive shock, and distributive type of shock. So hypovolemic shock is, now we have talked about that. You can understand now if there is any bleeding or if the patient doesn't have enough fluids in their system, they can get hypovolemic shock. So a cardiogenic shock is usually they can get an MI, an acute heart failure. So basically, it's an inability of the heart to contract properly. Obstructive shock you can have in trauma, something like a tension pneumothorax, a cardiac tamponade, where there is a mechanical obstruction to the pumping of the heart. Distributive shock is when the blood which is in the body is redistributed to the areas which do not really need it, whilst depriving the areas that actually need it. So types of distributive shocks are sepsis and what's the other one? Anaphylaxis. In both of those situations, the body's own immune system produces chemicals which cause massive peripheral vasodilation. So your peripheries will be warm and red, but the actual blood pressure is low because now your blood vessels are dilated. They are quite big. So when the blood vessels are dilated, the blood pressure invariably comes down. So from this scenario, it's very unlikely to be sepsis because one thing is they haven't mentioned the lactate, and the other thing is they haven't mentioned the any incidence of fever. So that is why it's quite unlikely to be sepsis. And why not anastomotically? Taraka, are you there?
Yeah.
Yeah. Why not anastomotically?
I don't have any idea about how to exclude this.
Yeah, again, it's a good habit to look at the timing. Anastomotically usually presents around post-op day 4, day 5. All of these things are like in practice, it can even present on day 2. But what we say is usually you have heard that mnemonic, right? Feeding water, wound, walking wonder. Have you all heard about that? So those are the causes of fever that are categorized according to the post-operative days. So wind is day 1. So on day 1, they can have day 1 to day 2, they can have fever because of basal atelectasis. So basically what happens is it's a small collapse of the lower lobes of the lungs due to immobilization of the patient. They can have fever because of that. Then water is about post-operative day 2, day 3. It's because of urinary tract infections with these patients on catheter, and they can have catheter-associated infections. And then wound. Wound is about on day 4, day 5. It's because of either a surgical site infection or it could be an anastomotic leak. Then walking. Walking is about day 5 to day 7. It's usually because of DVT, deep vein thrombosis. and then post after day 7, one day is pulmonary embolism. So basically, that's just a rough idea about the days that you can get these post-operative complications. So basically, I spent a little bit more time on this question because it's a good question. It's a very good question on how to properly come to a diagnosis when you get a post-operative complication case. Because to be fair, most of these things can present with these symptoms. So you have to mark the answer which is most likely. So we have chosen hypovolemia because of the fact that it's on post-operative day 2 and the patient has a high heart rate and blood pressure and reduced urine output, and very important, the central venous pressure is very low. That is the thing that you need to do. So his heart is underfilled. His heart is underfilled because he is not getting enough fluids. Is that clear? Anyone who has any doubts? If you have any doubts, ask. Okay, shall we move on to the next one then?
Excuse me, can I ask
Yes.
question?
Yes, sure.
Anastomotic leak, what is the typical feature?
So typical features are so it's going to be from an SBA perspective, it's going to be about day 4 to day 5. Okay.
Okay.
Patient will usually have tachycardia, increased respiratory rate, and will complain of abdominal pain. If the patient has a drain, you might see some feculent feces-like material in the drain, and the patient will have fever. So those are typically the cardinal signs of a anastomotic leak. Clear?
Okay, thank you.
So let's go to the next one then. Okay. So a 45-year-old woman undergoes laparoscopic cholecystectomy, is given IV ceftriaxone induction of anesthesia. Immediately afterwards, she becomes profoundly hypotensive, tachycardic, develops bronchospasm and a widespread urticarial rash. So what is the most immediate management? Okay, let's select someone else. Jayani, did you do the paper? Did you do this question?
Yes.
Okay. So from these options, so what is the patient having now? What is the diagnosis?
Anaphylaxis.
Anaphylaxis. Very good. Okay. So what is the immediate thing that you need to do when a patient has anaphylaxis?
Adrenaline.
Sorry,
Adrenaline.
adrenaline. Okay. What is the route of adrenaline that you are going to give? IV or IM or oral or what?
IM. IM.
IM. IM. Yes. Why IM and not IV? Not sure. So when the blood pressure is this low, they can have a collapse of their peripheral circulation. That means you can't even see their veins properly. So even if you give this adrenaline intravenously, it might not have an immediate action in the body because of the collapse of the peripheral circulation. So giving it intramuscularly, IM, is much better because the muscles are very richly perfused with blood. So when you give it IM, it will have an immediate action. Okay, so good. So whenever you have an anaphylaxis, the management is IM adrenaline. What's the dose?
0.5.
0.5 ml. Good. 1
1
in
in
1,000. Excellent. Very good. Yeah, that's a dose. 0.5 ml, 1 in 1,000. And again, if someone asks you the management in a viva also, along with this IM adrenaline, make sure that you always say, I will stop the drug which is causing the anaphylaxis. Or drug or food or whatever which causes anaphylaxis. That's also very important to mention. Okay. I will immediately stop the whichever allergen is causing this anaphylactic attack. Okay. Okay. So from these options which are given, actually, unfortunately, there is no IM adrenaline. So from these options, what do you think is the correct answer? What's the best answer? IV?
Adrenaline.
IV adrenaline. So now we discuss now why IV adrenaline is no point, it's no use. Peripheral circulation is collapsed. Won't help the patient a lot. So unfortunately, adrenaline, there is no good option with adrenaline. So that is out. So from these rest of the four, what do you think?
Antihistamine.
Sorry? Antihistamine.
Hydrocortisone.
Hydrocortisone.
Hydro.
Yeah, that's a good answer. So intravenous hydrocortisone is the answer from the options that have been given. I think IV hydrocortisone is the best answer that we can choose. The reason being, let's look at the other. Anyway, now we know no IV adrenaline is out. So then rapid intravenous fluids. In practice, we will definitely give rapid intravenous fluids along with the IM adrenaline, IV hydrocortisone, IV chlorpheniramine, no IV piriton, and we will give them rapid infusion of IV fluids in white bore cannulae. But the issue is it says rapid intravenous fluids only. That is the issue with that stem. So you can understand why we can't mark it as true. Then the next one is cardiopulmonary resuscitation. So is there any indication to give CPR at this moment? No, patient has not gone into a cardiac arrest. So there's no indication for cardiopulmonary resuscitation. Intravenous histamine is correct. That is also correct. I agree. But in an anaphylactic attack, after IM adrenaline, the next most effective agent is IV hydrocortisone. Then only comes IV antihistamine, or IV piriton, or IV chlorpheniramine. So based on these answers, the best is IV hydrocortisone. Did everyone understand that? Any questions? This anaphylaxis protocol should be very clear to you. I'll repeat it one more time. Immediately stop the offending drug. Give the patient IM adrenaline 0.5 ml 1 in 1000 IM intramuscularly, usually given to the anterolateral aspect of the thigh. Okay. Then IV hydrocortisone, if you want to know the dose, 200 milligram, and IV chlorpheniramine 10 milligram, and you start the patient on a bolus of IV fluid. That is the anaphylaxis protocol. Very simple. You have to do all of these when the patient has anaphylaxis. Is it clear? Everyone okay?
Can we give like there's already IV
Sorry?
access?
Sorry, I couldn't hear you properly.
There's already an IV access, so can't we give intravenous?
Yeah, but the thing is, even if we give adrenaline from that IV access, the veins themselves might be collapsed because of the low blood pressure. So it won't go properly to the heart and it won't get circulated in the body properly. That's why we give, even in patients who have IV access, we give IM adrenaline because of that. Because the muscles in this situation, when the patient's blood pressure is 60/30, in that situation, the muscles actually have a much better blood supply than the peripheral cannulas, than the peripheral veins. Understand?
Yes.
Yeah. That is the reason we will choose IM adrenaline. Okay?
Excuse me.
Yes.
You told that we can't give adrenaline because of peripheral circulation is collapse. So
Yeah.
we should give IM, and the first
IM, yeah.
answer is also IV hydrocortisone. So IV.
That's true, yeah. But the thing is that the IV hydrocortisone action is quite different from the action of IV adrenaline. IV adrenaline tends to dissipate amongst the circulation very quickly, while IV hydrocortisone stays a little bit. It persists. So
Okay.
all of these have been like all of these the whole anaphylaxis protocol has been designed with evidence, right? So different people have tried all of these things.
Okay.
So according to those things, they have according to multiple research studies and everything, only they have made this anaphylaxis protocol. So in that, adrenaline as a drug in this setting is more effective when given IM, intramuscularly, rather than IV. Whilst IV hydrocortisone is effective because the morphology of those two drugs is vastly different. The problem is that when you give IV adrenaline, it doesn't circulate amongst the circulation as effectively as IM.
Okay, understand. Thank you.
Okay. So shall we move to the next question? Okay. So a 40-year-old woman is admitted with acute appendicitis. She also has a history of poorly controlled asthma with frequent night symptoms and a recent hospital admission. What is the most important step before proceeding with anesthesia? So, Naveed, what do you think? What do you think about this? What do you think the answer is?
So I think the answer is C.
Optimize asthma control. Okay, why? Why is it C? Not sure. So number like in a vibe also you need to be able to back up your answer. So you have to get used to. So you don't have it's not you don't have to know a lot of medicine to answer a question like this. So why do you think it's C? So now when you get a question like this, you always look at the patient's problems. So this patient has one problem is acute appendicitis. Next problem is poorly controlled asthma. So it's probably it's not mild intermittent, right? The severity is much higher. So she's having frequent hospital admissions as well. So in a patient with bronchial asthma, in an unoptimized patient, they can undergo a bronchospasm with the general anesthesia very easily. So they can have respiratory even with a simple cough and cold. If the patient is not optimized properly, optimized in the sense of what we do is we give the patient some salbutamol and budesonide nebulization, and then we take him back to the theater. If we don't do that critical step, if we don't nebulize the patient, there is an extremely high chance of this patient developing an intraoperative bronchospasm when you give general anesthesia. When you give general anesthesia, you usually put in an endotracheal tube or an LMA, laryngeal mask airway. So when you do those procedures, when you're constantly irritating the trachea and the bronchi, very easily it can cause bronchospasm. So in a patient who is already prone to get bronchospasms because of asthma, you're just asking for trouble if you don't optimize this patient before taking him to the theater. Since this patient is having bad episode of asthma, it might even make more sense to treat the asthma at the moment and the appendicitis with only antibiotics and postpone the surgery as an interval appendicectomy to do it when the patient's asthma is optimized. So imagine so in the short term, you nebulize the patient, you give the patient maybe IV steroids, but when you auscultate the patient, still there is bronchi, there are features of these bronchospasms. So in that case, we can't go ahead with the surgery. It's extremely dangerous because the chance that the patient will die from a bronchospasm is higher than the chance that the patient will die from acute appendicitis. So especially when they have worded it like this, poorly controlled asthma, frequent night symptoms, recent hospital admissions, you need to definitely think about that. So because you can manage appendicitis with antibiotics as well. So the answer is C. So A, start prophylactic antibiotics. You can take that as an answer, but it is not the most important step. Give low molecular weight heparin, that's not an answer. So this patient does not have a very high risk of DVT. So that's definitely not an answer. Stop oral fluids 6 hours prior. You stop clear liquids only 2 hours prior to surgery. 6 hours for solids and semisolids. Okay. Actually, in children, even until 1 hour before the surgery, you can give them clear fluids. In adults, we tend to keep it for about 2 hours. And obtain a baseline ECG. Definitely, in a 40-year-old patient, they haven't mentioned about any previous cardiac complications, ECG is not even a must. Some anesthetists will request, but ECG might not even be needed. So from all of this, the answer is optimize the asthma control. So Naveed, you came to the answer, but you need to know why the others are wrong as well, okay? So which is the most important step before proceeding with anesthesia? So always look at the wording of the SPA. Any questions? Okay, then let's go to the next one. So 23-year-old male presents with a 12-hour history of central abdominal pain that has migrated to the right iliac fossa. He has nausea and anorexia. On examination, his temperature is 38.2 degrees, pulse is 110, localized tenderness and rebound tenderness are present in the RIA. White cell count is 15,000. Is the most appropriate next investigation? Hirunya. Yeah. So what do you think is the answer to this? So what's the diagnosis? You have to know the diagnosis.
So,
What do you think?
So I think the diagnosis, according to this, is acute appendicitis.
Yeah.
So,
do you need anything else to diagnose in this patient, a 23-year-old male? Is this enough for you to reach a diagnosis? Is the information that has been provided to you in this SBA enough for you to reach that diagnosis? Or do you need anything more?
It would have been better if we can have an image as well, if there's information in the appendix. But since there's diagnostic laparoscopy is given, so we can have a look at the abdomen, and if it is appendicitis, then we can go for the treatment as well along with it. So I chose the answer D for that.
Yeah, that is the correct answer. But yeah, I mean, I want to sort of discuss with you regarding the necessity for ultrasound scan abdomen. Okay, one thing we need to understand is an ultrasound scan abdomen can pick up appendicitis, but the sensitivity and specificity is quite low. It's not very sensitive because of the fact that the appendix can be underneath multiple loops of bowel, other organs. If it's something like a retrohepatic appendix, it may be under the liver. So an appendix in itself is quite difficult to visualize via the ultrasound. So it is unreliable, first thing. And an ultrasound scan is more useful to rule out the other diseases rather than actually diagnose appendicitis by itself. Always, as a principle, you all need to know that appendicitis is a clinical diagnosis. Okay? As a rule, you all need to understand that. But if if the gender of the patient was changed to female, then of course, what you said is true. Having an imaging is better because you can go for an ultrasound scan abdomen due to the fact that in a female, ovarian cyst accidents also present in a very similar manner. Very similar manner they present, but in this specific SBA, migratory RIF pain, nausea and anorexia, high temperatures, rebound tenderness in RIF, elevated WBC count, even though we don't use it, Alvarado score, I think most of the components of the Alvarado score are mentioned in this SBA. From all of this, definitely you will have to go for a laparoscopy. And so so Hiruna, tell me some differential diagnoses for a 23-year-old male who comes with RIF pain other than appendicitis.
They can have a cholecystitis as well.
Cholecystitis will be towards the right upper quadrant, a bit higher, just subcostal like. Anything else?
Hernia probably.
Okay, they can have probably an incarcerated irreducible inguinal hernia. Okay, anything else?
I'm not sure.
What do you think? So think of the common causes. So they can have a ureteric calculi. They can have a stone.
Okay.
They can have urinary tract infection. Rarely they can have things like Meckel's diverticulum. So those are all differential diagnoses for right iliac fossa pain. Okay. So but with this description, it is appendicitis and nothing else. And the next appropriate step in the management is to go for a laparoscopy. Okay. Okay, we go on next question. Everyone understands why the next other answers are not CT and MRI. Obviously, you would not do for a benign condition like this. There is no indication. Colonoscopy, of course, will not be done. It's colonoscopy typically is done for when there is a chronic right iliac fossa pain, which you can't find a cause for. Okay. So, okay. Next question. 65-year-old male presents with painless progressive jaundice, severe pruritus, weight loss of 8 kg over 2 months. On examination, is deeply jaundiced, has a palpable non-tender gallbladder. Liver function tests show bilirubin 280, ALP 950, gamma HCG, so almost all of these are elevated. AST/ALT mildly elevated. What is the most likely diagnosis? Okay, who is going to be the next? User 3 was a zebra profile picture. Hello. Not there. Okay, then let's go back. So, Taraka, what do you think? How will you approach this?
This mm, direct hyperbilirubinemia.
Yes.
Um,
What else?
that means that's obstructive jaundice.
Okay.
Direct means and gallbladder is non-palpable. That means
No. Palpable. Palpable was it?
yeah, palpable.
Palpable, non-tender.
Yeah, palpable. That's mean not answer is not the gallstone. Maybe
Okay, good. What is that law? What do you call that law?
Coursius law.
Coursius.
Yeah.
Yeah. Coursius law. Okay,
And
good.
then that can be a carcinoma of head of pancreas or cholangiocarcinoma. Both
Yeah.
cause,
How to differentiate between the two?
and in cholangiocarcinoma, liver is affected and ALT/AST elevate, as I think not sure. And carcinoma of head of pancreas just obstructed below the CBD and not elevate AST/ALT that much. So that's why I got the answer is as cholangiocarcinoma.
You chose cholangiocarcinoma as the answer.
First, I thought that carcinoma of head of pancreas. After that, when I see AST/ALT elevate, then I choose cholangiocarcinoma. Not sure.
So an AST, it's not a very high elevation, no? So it's a very mild elevation. So 45 and 50. So the issue is that in this question, from cholangiocarcinoma and carcinoma of the head of pancreas, it is quite difficult to differentiate. Yeah. Because a cholangiocarcinoma at the distal part of the CBD, that means near the head of the pancreas, towards the distal CBD also can present in the same way. Because even a periampullary cancer can be a cholangio. So so basically for this presentation, it could be either carcinoma head of the pancreas, cholangiocarcinoma, or a periampullary carcinoma. Those three are a main differential diagnosis. So in this situation, we have been given two, cholangio and carcinoma head of the pancreas. So then we have to think which is more common out of those two, because they have what is the most likely diagnosis. So when you look at it that way, carcinoma head of the pancreas is more common than cholangiocarcinoma. Yeah. And this AST/ALT elevation can happen in both conditions to a mild degree. What you mentioned earlier about AST/ALT being elevated in cholangiocarcinoma is more in terms of a Klatskin's tumor. Klatskin's is one of the exceptions to Coursius law when there is a cancer right at the confluence of the common hepatic duct, right above. That means above the gallbladder. So the gallbladder won't be palpable. So right at the hepatic hilum. So cholangiocarcinomas like that can sometimes extend intrahepatically. That means they can extend into the liver, into the bile ducts, into the intrahepatic bile ducts. Then you can have a significant elevation of AST/ALT. This 45-50 level of AST/ALT usually in most of the patients with direct hyperbilirubinemia, they will have this elevation. So from those two, from cholangio and carcinoma head of the pancreas tends to be more common. So we can choose, but I think because this is a recall question, this should have been hyalocholangiocarcinoma. that must have been dropped from the question, because otherwise it's not a very fair question to ask, because both of these entities can cause the above symptoms. So definitely what you need to identify is he has the cancer, because he has a weight loss of 8 kilograms over 2 months. And painless progressive jaundice. So painless progressive jaundice and a weight loss are both very high markers of hepatobiliary malignancy. So you need to identify as a malignancy. And in this Coursier, and you have to consider Coursier's law as well. And in that, it can't be gallstones, no. So anyway, they won't have weight loss of 8 kg in gallstones, and the ALP and everything won't be elevated. Okay. So it can be either cholangiocarcinoma or carcinoma head of the pancreas. Okay, is it clear? It's not primary biliary cholangitis. I mean, there is no disease called primary biliary cholangitis. It's primary biliary sclerosis and sclerosing cholangitis. So it doesn't sound like both of those are autoimmune conditions. Anyway, this doesn't sound like an 65-year-old man with. So it definitely sounds like a malignancy, you know. So it should be one of those two, either cholangio or a carcinoma head of the pancreas.
Excuse me. Usually, viral hepatitis and cholangitis both have fever, right?
Yes,
Usually.
but cholangitis will have fever with chills and rigors and very high spikes, like 103, 104. In viral hepatitis, usually it's more of a low-grade fever, like an evening pyrexia sort of picture.
And the periampullary carcinoma cause blood mixed stools, right?
Periampullary carcinoma will cause intermittent hematemesis and melena along with silver gray stools. Silver gray stools appear because, and that will also not always happen intermittently when the tumor necroses. When the tumor necroses, it will pass in the GI tract, and because there is obstructive jaundice anyway, there is no bile which is reaching the large bowel. No? So because of that, the blood will mix with the pale color stools and it will give rise to silver gray stools. That is the typical presentation in periampullary carcinoma. Actually, in this specific question, I think cholangiocarcinoma. Actually, what you said earlier, I think cholangiocarcinoma is a better answer. Why do you think so? I just realized it because elevated ALP and gamma GT.
Actually, I didn't have any idea about
Yeah, that's subtle. Because I have seen enough and more carcinoma head of the pancreas patients also have elevated ALP and gamma GT, but usually ALP and gamma GT tend to be more elevated when it comes to bile duct pathology. So because of that, I think cholangio is a better option in this. It can be either cholangio or carcinoma head of the pancreas, but purely because of this ALP gamma GT, cholangio is a better answer. So you have to consider that as well. So just in the back of your mind, remember ALP is elevated in bile duct conditions, when there are bony conditions, and when there are lung conditions. So those are the three situations where ALP is elevated. Gamma GT is elevated when patient is a chronic alcoholic, or again when there are bile duct issues. So because of the high ALP and gamma GT, I think a cholangio is more likely in this case. I think they were expecting us to choose cholangio. So we'll take the answer as A for that. Okay, good. Go to the next one. Okay, 32-year-old woman presents with right upper quadrant pain, high fever and jaundice. Examination reveals tenderness in right hypochondrium. Blood tests show elevated bilirubin, direct hyperbilirubinemia, ALP elevated, WBC 16,000. What is the most likely diagnosis? Okay, Jayani, what do you think?
Acute cholangitis.
Acute cholangitis. Yeah, this is easy, no? I agree with you. So what's the triad called, Jayani? These symptoms?
Charcot's.
Yeah, Charcot's triad. So right upper quadrant pain, high fever, and jaundice. Now, actually, we have moved on from Charcot's triad to another thing called Raynaud's pentad. That means 5 symptoms. So along with right upper quadrant pain, high fever, jaundice, you have confusion as well as low blood pressure. So those collection of those 5 signs and symptoms are diagnostic of acute cholangitis. It's called Raynaud's pentad, okay, because there are 5. So it's Jayani, tell me why it's not cholecystitis. What do you think? Will cholecystitis have jaundice typically?
No.
No. So yeah, cholecystitis typically will not have jaundice and elevated, will not have a hyperbilirubinemia. So we can rule out cholecystitis like that. Why not viral hepatitis? Sorry?
Mild fever.
Yeah, high fever. We talked about that earlier. So it's this is a high fever and looks like a very acute presentation. Viral hepatitis also can present acute, but it's not an emergency like this. Cholangitis is an emergency, remember. And gallbladder carcinoma? Yeah. Yeah, no, they haven't mentioned anything regarding. So if they wanted us to pick gallbladder carcinoma, they might mention something about liver metastasis on a CT scan, and intraoperative there may be a gallbladder polyp. So I think none of those are mentioned. And anyway, it's very rare. And acute pancreatitis? Yeah. Which is relieved on bending forwards. And usually they'll mention an serum amylase level as well. So because of all of those, you can say that the answer is cholangitis. Okay, next question. 58-year-old man with cirrhosis presents with massive hematemesis and hypotension. Stabilized with IV fluids and blood transfusion, urgent endoscopy shows large bleeding esophageal varices. What is the most appropriate immediate management? Naveed, what do you think is the answer? Hello, Naveed, are you there? Okay, Tarak, what do you think?
Endoscopic band ligation with IV terlipressin.
Yeah, so that's the best answer. So patient has a massive upper GI hemorrhage. So tell me a little bit about the management protocol for a massive upper GI bleeding. Quickly, just go through the basics. In a Viva, if they ask, how will you answer?
In massive upper GI bleeding, we have to
There is an opening statement that you need to use in every emergency. So we stabilize this patient according to the ABCD protocol. Beginning with stabilizing his airway, because people who have massive hematemesis can have airway issues. Optimizing his breathing by providing him with high flow oxygen, and then moving on to his circulation. So I will establish wide bow cannulae in bilateral and cubital fossa. While establishing IV access, I will take blood for grouping and DT, full blood count, serum lactate, liver functions, coagulation profile, blood culture if you suspect any sepsis or whatever also. And I will start him on IV crystalloids, about 1 liter, bolus 500 ml boluses from bilateral sides. and I will then ensure that he receives intravenous terlipressin, 2 milligrams stat, 2 milligrams 6 hourly. I will transfuse him with blood as soon as possible. He makes sure he's connected to a multi-para monitor, has a urinary catheter in order to check his volume status. And based on his resuscitation, I will decide on the next management. Okay? Whatever emergency, start with, I will stabilize this patient according to the ABCD approach. Some examiners might get annoyed with that because everyone has been taught that now. But not mentioning it is a fatal flaw. So it's even in the postgraduate exams, even in the exam which determines if you become a consultant surgeon or not, if you don't mention this line, you will fail the station, even though it's overused. Always in every emergency, you have to make sure that is there. Okay, so just going into the basics of upper GI bleeding, let's talk about upper GI variceal bleeding. So variceal bleeding is because of chronic liver cell disease causing portal hypertension. Yeah. So in an acute setting, definitely, like I mentioned, you have to resuscitate the patient. Then to go for the definitive management, it will depend on whether the varices are esophageal or fundal in the gastric fundus. Okay.
Yeah.
Esophageal varices, you will do your gold standard is endoscopic band ligation. Whilst for fundal varices, what we do is acyanoacrylate glue injection. So basically, it is a glue to that blood vessel that we see, the big blood vessel, we inject a glue, which causes the sclerosis and thrombosis of the blood inside, and it will not bleed then. Okay?
Okay.
Fundal varices. Along with that, you have to give IV terlipressin, 2 milligram every stat dose and then 4 hourly. And you need to optimize the patient's portal hypertension, either pharmacologically with beta blockers, or if the patient is refractory, final step is TIPS.
Tips.
So TIPS is transjugular, intrahepatic
Water systemic shunt.
Yes. So basically, you make a shunt between the portal circulation and the systemic circulation to reduce the portal pressure. So if this patient's bleeding is not controlled with this band ligation, so your next steps could be sclerotherapy. You can do argon plasma coagulation. Failing all of that, final option is this sense-taken tube insertion. So basically what it is it's a balloon in the esophagus. You create a tamponade effect within the esophagus. You deploy the balloon and then with an external pump, it's like a hand pump, you pump it and you can occlude those bleeding vessels. But the issue with a Sengstaken tube is because you're putting a lot of pressure on the wall of the esophagus, it can cause esophageal wall necrosis when you keep it for more than 24 hours. So that's an important complication of Sengstaken tube insertion. You just know a little bit about that, okay? All right, clear?
Yeah.
Okay. Okay. 64-year-old man with a 15-year history of ulcerative colitis presents with a recent change in bowel habit, anemia, and weight loss. Examination reveals pallor. What is the next best investigation? Hirunya, what do you think?
In this stem, according to the stem, since the patient has been having this ulcerative colitis for over 8 to 10 years, so I would suspect there's
15 years.
dysplasia. Yeah.
Dysplasia,
15
very good.
Yeah, dysplasia. Therefore, I would definitely go for biopsy. And so the option colonoscopy with biopsy is more apt for this stem.
Yeah, very good. So when someone has ulcerative colitis for more than 15 years, I think they have almost a 70 to 80% chance of having dysplastic or cancerous lesions. So in any inflammatory bowel disease, the longer it is there, the higher the risk of malignancy. So in ulcerative colitis, we say that the 15 years is like the cutoff that they give. More than 15 years, the chance of malignancy is very high. So definitely, since he's displaying some recent changes in his disease status as well, you would definitely need to go in, do a colonoscopy, And any suspicious lesions that you see, you need to biopsy them and send them to the histology lab to see if there is a malignancy. So let's talk about the other options. So why is it not a CT colon, Hirunya?
Because it's only the imaging that we get from the CT.
Yeah, we can't get a tissue diagnosis, no?
Diagnosis, yeah.
Yeah. Barium minima?
Barium minima, if there's like, once again, we don't get the tissue picture for this.
And typically,
ultrasound,
we will not visualize the proximal colon. That means the right side will not be visualized quite well with the barium minima. It's okay to see the left side, but the right side is not very well visualized. Anyway, ultrasound scan abdomen and MRI pelvis both out, because ultrasound scan abdomen again will not give you a tissue diagnosis, and it's very, very unreliable investigation to look for intraluminal pathologies. That means problems within the bowel wall. It's not a good investigation. MRI pelvis will give you an excellent picture of the rectum and the sigmoid colon, but it will not help you with the descending sphenic flexure transverse colon. So definitely we would need to go for full colonoscopy with biopsy of any suspicious lesions. Okay, good.
So I have a question there.
Yeah.
The stem says like 15 years. So is there like a grading or like a rough idea that we can predict that an ulcerative colitis, which has been prolonged for a long period of time, that would lead to a carcinoma? Like, I mean, is
you
there
mean
like
according to the time?
Yes, according to
15 years. Yeah, 15 years is exactly the cutoff.
Okay,
Once after 15 years, we recommend actually yearly surveillance colonoscopies to detect any dysplastic lesions.
Okay.
So usually the incidence of carcinoma is directly correlated with the disease activity as well. So if he has had multiple episodes, all these Crohn's disease and ulcerative colitis both are remitting and relapsing diseases, right? You have them sometime, then you treat, then it relapses, then remits, and then it comes back, relapses again. So more relapses also is correlated with a higher risk of malignancy. So usually 15 years is the actual cutoff. More than after 15 years, the chance of these dysplastic lesions occurring is very high. I told you about almost 70 to 80% sometimes in some studies. So definitely they will have to undergo surveillance. And also he is an elderly man. So the age is also a factor for him to undergo a colonoscopy. Okay. So 54-year-old alcoholic presents with severe epigastric pain radiating into the back, vomiting and fever. Serum amylase is 1200. Normally is more less than 100, but it's the most appropriate first imaging investigation. Naveed, are you there? Hello. Okay, then Jayani, what do you think?
Ultrasound scan.
Ultrasound scan abdomen. Okay. So why do you think the answer is ultrasound scan? Why not CT, or why not the CT?
Ultrasound to exclude other diagnoses.
You want to rule out the other problem. Usually CT abdomen is indicated in now we know the diagnosis here is acute pancreatitis now. So CT abdomen usually is indicated in cases where there is a severe diagnostic doubt, or when there is evidence of complicated pancreatitis. Things like infected pancreatic necrosis or an infected pancreatic pseudocyst, or things like that. In that situation, a CT abdomen is indicated, but it is not the first imaging investigation. ERCP, MRCP again. So if in an acute stage of pancreatitis, ERCP is not indicated. It can actually worsen the pancreatitis. We all have heard of ERCP-induced pancreatitis, so it can actually worsen the pancreatitis. So once after the acute, so actually the only indication for an ERCP whilst the patient has a pancreatitis is cholangitis with pancreatitis. If the patient is presenting with both cholangitis and pancreatitis at the same time, so that can happen because of a gallstone. A gallstone can migrate to the pancreatic duct, causing pancreatitis there, and it can also settle in the distal common bile duct, causing jaundice and a cholangitis. So in that situation, you will need to do an ERCP to remove that distal CBD stone and to put a stent there, because then you can drain the obstructed infected system. So because if the patient has both cholangitis and pancreatitis, their mortality is very high. So you need to address at least one of those. So MRCP, why not MRCP? So MRCP will only help you if it's help you reach a diagnosis if it is a ductal pathology. That means there's something wrong with the bile duct which is causing the pancreatitis. So it has been mentioned that he's an alcoholic as well. So probably alcohol is the cause of his pancreatitis. So it will not help us here. And diagnostic laparotomy is definitely wrong. We will never open the patient with pancreatitis unless he has infected pancreatic necrosis and the patient is getting worse and worse and worse. And we need to remove that infected necrosed part of the pancreas. That is the only time you will open the patient with pancreatitis. Clear now? Any questions, Major Jack? Okay. Okay, next question. 40-year-old man presents with hematemesis following repeated episodes of forceful vomiting after an alcohol binge. He's hemodynamically stable. Endoscopy shows a linear mucosal tear at the gastroesophageal junction. What is the most likely diagnosis? Taraka, what do you think it is?
Malarial tear.
Okay. So why is it not Bohev syndrome? What is Bohev syndrome?
Boas syndromes occurs due to therapeutic procedures associated with esophagus.
Usually no. Bohev syndrome also, the main precipitator is almost similar to malarial tears. I mean, forceful vomiting, forceful regurgitation will cause a Bohev syndrome. But the thing with a Bohev syndrome is it is a full thickness esophageal rupture. That means all of the food contents which are in the stomach and the esophagus can leak out into the mediastinum. It's a very catastrophic event. Whereas a malarial tear is only a mucosal tear. Only the mucosa is tear and it's linear. It's straight tear of the mucosa. From the upper GI endoscope, you can very nicely see it. Whereas Bohev syndrome is the esophagus that is there is completely ruptured. So there is like a segment here with there is like where all of the food particles and everything can leak out into the mediastinum. So in this case, it's very obvious answer the malarial tear. So it's not esophageal varices because there is no massive bleeding and the endoscopy doesn't show any dilated esophageal varices. Peptic ulcer also unlikely. They haven't mentioned anything about an ulcer. And gastric carcinoma also very unlikely. They will definitely mention something about loss of appetite, loss of weight, malignant looking lesion or a leather bottle stomach or something like that. So none of those things are mentioned. Okay, so next question. A 45-year-old woman presents with a hard, irregular breast lump in the outer quadrant. Skin dimpling is present. No axillary nodes palpable. What is the best next investigation? Hirunya, what do you think is the answer?
So for this one, we need to do mammogram and core biopsy because we need the imaging as well for this.
Yeah.
Because it also says irregular breast lump, so irregular, which leads to the assumption that there's a carcinoma ongoing.
Yeah.
So we need to do the biopsy. So
yes, why not
imaging and
an
biopsy.
ultrasound breast?
Ultrasound will not give you the what do you call the cytological aspect of.
Okay, so what if there was no core biopsy here? If it was a decision between an ultrasound breast and a mammogram, what would you choose? So just as a rule, over 40 years of age, you can use a mammogram. Less than 40 years of age, the female breast is too dense for a mammogram to give you any accurate information regarding the lesions. So in that situation, you have to use an ultrasound scan. But in practice, usually both are done. An ultrasound scan of the breast and axilla, as well as a mammogram. And then according to that, you will do a core biopsy as well. So definitely, so you know your triple assessment now. So you need a clinical, radiological, and a pathological. You need results from all of those three in order to diagnose breast cancer. So clinical will be your breast and axillary examination. Your radiography will be mammogram, ultrasound, or in certain situations, MRI. And your pathological will be FNAC or a core biopsy. Although nowadays FNAC is out. FNAC is hardly ever done. Core biopsy is the one that is done. FNAC is done in the case of malignant axillary lymph nodes. So when there's a malignant lymph node, you can do an FNAC of the lymph node and you can see if there are metastatic there. But other than that, FNAC is very, very rare. It's not at all done for breast cancers because of the fact that it will not give you the immunohistochemistry. So immunohistochemistry is one of the most important prognostic markers and it helps you plan your chemotherapy and hormonal therapy as well. So because of that, core biopsy is the one that is now gold standard. As for MRI breast is done in several situations. That also you all should know. When there is a very strong family history of breast cancer and you suspect something like a BRCA mutation, BRCA1, BRCA2, Peutz-Jeghers syndrome, if there is any genetic predisposition, you can do an MRI breast. Also, in very young females who are presenting with suspicious lesions, and if the ultrasound scan is equivocal, it's not giving a lot of information, then you can again go for an MRI. So in patients who have breast implants or breast augmentations, again, MRI breast is the gold standard to visualize them. Also, in patients who have previously undergone surgical procedures like double-wide local excisions, they have undergone radiotherapy and chemotherapy in those situations. Also, again, an MRI is indicated. So those are some of the situations that an MRI is indicated. As for excision biopsy, we will never do an excision biopsy on a suspicious breast lump. So that is anyway out. Okay.
So I have a question there. Like, in case if the option A has been given, like, in case if the option A had been ultrasound breast scan with core biopsy, what would we choose?
Still
like
no.
between A
Still
and
mammogram.
B?
Still mammogram.
Still it'll be
Because
mammogram. Okay.
more than 40 years of age.
Okay.
So it's better. Yeah. Mammogram is better at detecting malignancies than an ultrasound scan. The issue is that in women less than 40 years of age, the breast is too dense for us to get any useful information. Okay, Hirone, you do the next one also. It's similar, not similar, but same thing. 26-year-old woman presents a mobile, painful breast lump that fluctuates with the menstrual cycle. What is the most likely diagnosis?
For this one, I chose the answer B because it says the breast lump is painful.
Okay.
Had it been just mobile without a painful breast lump, then I would have chosen fibroadenoma. But since it says painful breast lump, so I chose
So what is the
fibrocystic
usual
disease.
age group for ladies to get fibrocystic disease?
Age group is
Generally little older, right?
a little older, yeah, older
Yeah,
than
so
40 years.
usually the perimenopausal age group.
Yes,
And usually in fibrocystic disease, they will complain of this lumpy feeling in bilateral breast that will change with the fluctuations of their menstrual cycle as well.
which is
So they might complain of multiple lumps, or their imaging might show multiple cysts, and it tends to be a bilateral problem. So obviously these three out, no, carcinoma, fat necrosis, and galactosele. So for it to be a carcinoma, it may need to mention about hard, irregular, axillary lymph nodes. All of those need to be mentioned. For fat necrosis to be the answer, there needs to be a preceding history of trauma. For a galactosele to be the answer, they need to mention something about pregnancy or breastfeeding. So our real two contenders are either a fibroadenoma or a fibrocystic disease. Fibroadenoma can also fluctuate with the menstrual cycle and be painful. Most fibroadenomas are painless. I agree with you. I think more than 70-80% of them are painless. But sometimes they can have pain, especially associated with their menstruation as well. So the fact that it's a young lady, 26 years old, it's mobile, and it fluctuates with the menstrual cycle, you think the best answer in this case is is a fibroadenoma. The painless and painful, it's painless, I agree with you, but it can be painful as well. When you have seen enough patients, you will realize that fibroadenoma patients also will come complaining of pain. So that is the reason why we have chosen fibroadenoma. I mean, I chose fibroadenoma. Fibrocystic disease generally tends to be a bit older, and usually in that stem they will mention something about lumpy breasts or bilateral lumps in breast that fluctuate with menstruation. So actually, my fibroadenoma is considered the aberration of normal involution and development. It's called ND. So it's actually not even considered a disease anymore. So these are changes of the breast tissue that occurs with the maturing of a woman and with her menstrual cycle. So just read up on that if you all have time. Aberrations of normal development and involution, ND. So those are considered very benign conditions. And actually, if the fibroadenoma is small and not causing any issues, there is no indication to excise it as well. You can just observe. Okay. If it's more than 5 centimeters, then only you can call it a giant fibroadenoma, and those have been associated with malignancy. So otherwise, normal small fibroadenomas which are not causing any problems, which is not painful, cosmetically also, if the patient is fine with it, we can actually observe. Okay, Tarak, 56-year-old woman presents with bloodstained nipple discharge, no obvious lump. What is the most likely diagnosis?
I choose the answer as ductal ectasia.
Ductal ectasia. Okay. So why? Back up your answer.
Fibroadenoma.
Age group එක හරි.
I exclude C, D, E, and I
Why
don't
not
exclude
B?
the introductory. Usually, ductal ectasia causes green color nipple discharge, right?
Yeah, they can have
As
multicolored nipple discharges.
Yeah.
Duct ectasia will cause bloodstain, brown, green. And usually the demographic for duct ectasia are 50-year-old women, history of smoking, multiparous, and with multicolored nipple discharge. So that will be usually the stem if they want you to go with duct ectasia. So if they are saying just simple blood-stained nipple discharge, then it's a good idea to go for the introductor papilloma.
Yeah. First, I marked that that as the answer, and here is no obvious lump. I thought that in intraductal papilloma there is a lump. That's why I choose that answer.
No, sometimes you can't feel the lump because it is so in the nipple areal complex that the only way you can detect the lump is with a ductoscopy. That means you have to put a camera into the duct and you have to visualize.
No.
If those facilities are I think the ductoscopy is not available in Sri Lanka at all. I have never seen. So what we usually do in a situation like this is we do a excision of the nipple areolar complex. And then only we send it to the pathology lab and then only we can see the papilloma which is inside that duct. Excision of the nipple areolar complex meaning we excise the ducts. You can excise either the single duct which is causing the discharge or you can excise all of the ducts. The thing it's called a microdectomy where you excise the single duct which is producing the blood, and if it is that you do in a younger female because if you may excise all of the ducts in case they want to breastfeed, then you can't, no.
Yeah.
But in an older female, now 56 years old, so probably she is probably menopause now, not gonna breastfeed anytime soon, no. So in that case, you usually do this called a Hadfield's procedure. Basically you are the retro nipple areolar complex system of ducts, you excise them all. ඔක්කොම අයින් කරනවා.
Okay.
Cosmetically, you will still have a nipple areolar complex, but underneath that, you will not have any draining ducts. So usually that is this is the typical presentation of an intraductal papilloma. You don't have to have a lump, okay? Lump එකක් තියෙන්න ඕනෙම නැහැ. Okay. So next one also Tarak, you do. 37-year-old woman has a solitary thyroid nodule. Ultrasound confirms a 2.5 centimeter solid hypoechoic lesion. FNAC result is follicular neoplasm. Type 3. What is the next best step in management?
I choose total thyroidectomy.
Total thyroidectomy. Why total thyroidectomy?
Solitary thyroid nodule is probably malignant, yes, because solitary, and it's a follicular neoplasm. FNAC result, follicular neoplasm. Repeat FNAC in 6 months is not the answer because this.
Yeah, it is definitely not the answer.
Yes, neoplasm is mentioned, so that's risky to wait another 6 months.
So follicular neoplasm, what are the two types of the follicular neoplasm?
Follicular neoplasm.
Two possibilities can be there. So it can be either a follicular adenoma or a follicular carcinoma.
Yes.
So follicular adenoma can be managed with a hemithyroidectomy. You only need to remove the side which has the lesion. Whereas for a follicular carcinoma, you have to take out the entire thyroid gland.
Okay.
So this Thai classification is the Bethesda classification. Okay, everyone needs to know about that. So Thai 1 is non-diagnostic, Thai 2 is benign, Thai 3 is follicular neoplasm, Thai 4 is probably malignant, and Thai 5 is a confirmed malignancy. So Thai 3 is when you have a bit of a diagnostic doubt. So in Thai 3 lesions, what we do when the FNAC result shows a follicular neoplasm is you optimize the patient and you operate and you do a hemithyroidectomy. If you have frozen section facilities available in your hospital, that means frozen section is you can send a pathology specimen to the lab in that moment itself and they will give you the result. So if frozen section is available, you can do the hemithyroidectomy and you can send the section to the lab. And then they will tell you whether this is a follicular adenoma or a follicular carcinoma. Because you can't differentiate that with just an FNAC. With the FNAC, you can't see capsular invasion and vascular invasion. That means if it's a carcinoma, it will spread beyond the capsule. If this is the capsule, if it's a carcinoma, it will spread beyond the capsule. So you can't see any of these things with just a simple FNAC.
Yeah.
But if you take out the entire nodule, when they examine under the microscope, they can see these metastatic cells which have spread out of the capsule. and spread along the blood vessels. So then they know this is not an adenoma, it's a carcinoma. Remember, an adenoma will never spread like this. So once they have confirmed, so if it is an adenoma, then the lab will tell you the diagnosis is follicular adenoma. So this is enough. We can just close the patient and come. But in case it's a follicular carcinoma, then we have to do the total thyroidectomy. So we have removed one side. So when the lab says that, okay, this is a follicular carcinoma, you need to do the total thyroidectomy, you can simply remove the other side as well. So that is the management in a type 3 lesion, okay? So as a principle in a follicular neoplasm or a type 3 Bethesda lesion, so the management is a hemithyroidectomy, okay?
Okay.
If you all have any questions at any time, you all can ask, okay? Okay, Jayani, next question is for you. 52-year-old woman develops tingling of her lips, carpopedal spasms, and muscle twitching 1 day after total thyroidectomy. On examination, Chvostek's two source signs are positive. Serum calcium is 1.55. It's low. What is the most likely cause? What's the answer, Jayani?
Hypocalcemia due to hypoparathyroidism.
Okay. So what is Chvostek's and what is true source sign?
Facial just facial
Not clear. Your mic is also not clear, Jayani. Chvostek's is when you tap the just in front of the tragus of the ear where the facial nerve is. It will cause an involuntary twitching of that ipsilateral facial muscles. So hypocalcemia causes hyperexcitability of the nerves. Because of that, you will have the Chvostek. But true source sign is what?
tremor.
No, true source sign. Yeah. So when you induce ischemia of the upper limb using a blood pressure cuff, it will cause a flexion of the wrist. Because the ischemia will also trigger the hyperexcitability. So basically the wrist will come like this when you inflate the blood pressure cuff. In addition to that, they will have perioral numbness. And extreme cases, they can have seizures as well as arrhythmias. The common arrhythmia that they get is important in medicine also. What's the common arrhythmia? Hypocalcemia by 10. What do you not together? So they get torsade do pointies, no? Twisting of the points. Yeah, it's a common one you get for hypocalcemia. So hypocalcemia can cause all of these if you don't catch it and treat it properly. So in this situation, probably due to a parathyroid gland ischemia or inadvertent removal of all 4 parathyroid glands, this patient has got a hypocalcemia. It's obviously not hypokalemia. None of these symptoms will present with hypokalemia. Hypomagnesemia can also cause hypocalcemia. It's quite a complicated pathophysiological process. You'll read about that. Hypomagnesemia can cause hypocalcemia indirectly. There is a relative deficiency in calcium in hypomagnesemia. But when you think about this entire MCQ, when you look at the entire stem, after total thyroidectomy, you won't get a hypomagnesemia, you'll get a hypocalcemia. Considering that, because of that, it's wrong. But just keep in the back of your mind, that hypomagnesemia can cause hypocalcemia. Okay? And hypernatremia, obviously no. Metabolic alkalosis also, it's quite obvious why it's not the answer. The metabolic alkalosis will not cause hypocalcemia. So in this stem, you need to recognize that the patient has hypocalcemia and the patient has recently undergone a total thyroidectomy. So even before coming to the stems, you need to know the answer needs to be in your head. Okay. So, Jani, next one also you do. 45-year-old man with thyroid nodule is diagnosed with medullary thyroid cancer. During staging workup, he is found to have bilateral adrenal masses and raised urinary catecholamines. Which hereditary syndrome is more likely? This is obviously a knowledge question. Nothing to think here.
2A and 2A.
Men 2A. No? So, what are the bilateral adrenal masses, Danny?
Pheochromocytoma.
Yeah, pheochromocytoma. So, what are the things in men 1? 3 P's. 3 P's. මොකද parathyroid hypoplasia, pituitary adenoma, අනිත් එක third one?
Pancreatic.
Yeah, pancreatic tumors. So what men 2A, what will they have? Medullary cancer
Pheochromocytoma and primary
and parathyroid hypoplasia. So men 2B is basically men 2A but with marfanoid habitus. And because of that, they can have mucosal neuromas also. So men 2B is the same as men 2A but with marfanoid habitus. Von Hippel-Lindau syndrome, usually they have kidney issues, multiple kidney cysts, multiple what do you call incidences of renal cell carcinoma. Yeah. And Lee-Fraumeni syndrome is a mutation of the p53 gene. P53 gene is an anti-cancer gene which is found in our body, and they will usually present with a more higher tendency for cancers, not these symptoms. Okay, clear now? Okay, we have Rashid. Do you mind doing the next question? Hello. Ibrahim Rashid.
Yes, sir.
Okay. So 65-year-old male smoker presents with calf pain after walking 200 meters is relieved by rest. ABPI is 0.65. What is the most appropriate next step in the patient's management? So what does he have now? What's the diagnosis?
Varicose.
Varicose. Why varicose? Have they mentioned anything about superficial veins?
No.
Yeah. So it's very unlikely to be varicose then, no?
It's intermittent claudication.
Intermittent claudication, correct. So is there any classification that you know of for intermittent claudication? Do you all remember? So there's a thing called the Fontaine classification. So the Fontaine classification you can divide. So basically what we need to understand is that this patient is getting calf pain because of an arterial insufficiency. There is not enough blood which is going down to his legs. That is why that we can see that because of we can get the clues because of the patient's age. He's a smoker, he's male, and he has calf pain. And they have also mentioned the ABPI. So ABPI is ankle brachial pressure index. So basically what you do is you mention the blood pressure at the brachial at the arm, and you measure the blood pressure at the ankle and you see the difference. Okay. So an ABPI of less than 0.9. ABPI of less than 0.9 says that this patient has peripheral vascular disease. That means the arteries which are supplying his legs are blocked. Like in the same way that you will get heart attacks because the coronary arteries are blocked, same way you get strokes because the cerebral arteries are blocked, you can get intermittent claudication. So you have several classifications. So I mentioned this Fontaine classification. So in Fontaine 1, it means the patient is asymptomatic. Fontaine 2 is that they have intermittent claudication. Fontaine 2 is subdivided into A and B. Fontaine 2A means that they will get pain after walking for more than 200 meters. Fontaine 2B is that they will get the pain less than 200 meters after walking for less than 200 meters. Then Fontaine 3 is they can have rest pain, and Fontaine 4 is that they will have ulcers, arterial ulcers, or tissue loss. And this ABPI is also categorized. If the ABPI, now I told you if the ABPI is less than 0.9, that means it is peripheral vascular disease. If it's between 0.6 and 0.9, then it is usually mild peripheral vascular disease that will only have intermittent claudication. So 0.3 to 0.6 is considered as moderate disease, while less than 0.3 is considered as critical limb ischemia. That means those patients will have rest pain as well as ulcers, tissue loss. So for this patient, what do you think the main answer is? Rashid, did you understand? Rashid, are you there? Oh, seems like he's not. Okay, Tarak, what do you think is the answer for this patient?
I marked as thrombolysis.
Thrombolysis. Okay.
B.
So why do you think he needs a thrombolysis? How do you manage peripheral vascular disease?
I thought that it's not, if the disease is not severe, you can manage it low molecular weight heparin, and then
So usually for peripheral vascular disease, we don't use low molecular weight heparin.
yeah, aspirin, right?
Yeah, aspirin.
Yeah. In DVT,
So
we use the
yeah, yes, exactly. Low molecular weight. In venous thrombosis, you use low molecular weight heparin. So the basic principles of management of peripheral vascular disease is first you have to grade the severity. Like I mentioned, did you understand that Fontaine classification, ABPI, how you get the severity? So the worst is critical limb ischemia. When the patient has reached critical limb ischemia, you have to do some sort of intervention, either surgical or endovascular with thrombolysis. But until the patient reaches critical limb ischemia, and when he's still in intermittent claudication, we can try to manage the patient conservatively. Okay?
exercise therapy and risk factor modification.
Remember, no matter which grade of severity they present to you with, the very first thing that you have to do is risk factor modification plus investigating for cardiac problems. Number one priority is that. Risk factor modification is what you need to do is start the patient on aspirin, start the patient on high dose statins, atorvastatin 40 or 80 milligrams, aspirin 75 milligrams, and some start on clopidogrel as well, but actually just one antiplatelet is enough. And then investigate for cardiac problems, do an ECG. If the ECG is normal, do an exercise ECG, do an echocardiogram, and assess the heart. If there are any changes in the echocardiogram, go for an angiogram and find out the blocks in the heart. Because the thing is that the heart will kill the patient faster than the limb. And then if the patient is still in this intermittent claudication, a Fontaine 2, basically in Fontaine 2, Fontaine 1 is asymptomatic. Now in Fontaine 2, then you can try these supervised exercise programs. So you will ask the patient to walk until they feel that anyway, they will have to walk for 40 to 45 minutes a day for 5 days a week. And you ask them to walk until they feel the pain. And then you ask them to rest. And then you ask them to again start walking. Like that, you basically, what you're doing is, now you have the main arteries to the leg are blocked, no, the posterior tibial artery, the anterior tibial artery, the femoral artery. Because of those blocks, you are trying to encourage the development of collaterals. Okay, when you exercise, you are trying to encourage the development of collaterals. Our blood vessels, more and more blood vessels will form and it will form collateral. So that is what you're trying to get. And so exercise therapy will not work for all patients. Typically, it works for only about 30 to 40%. But anyway, we try that before we go on for a surgical or an endovascular treatment. So once you have done that, and if it doesn't work, or if the patient is presenting with critical limb ischemia, either rest pain or tissue loss, then you have to invariably decide on, there are three treatment pathways that you can do. Two I have mentioned. You can do a bypass surgery. You can do a endovascular, that means using the X-ray machine, and using fluoroscopy. You can do a thrombolysis, which means you can go to the actual blood clot itself and you can put in chemicals to dissolve that blood clot, and then you can put a stent. Like stenting in basically it's like stenting in coronary arterial disease. You can do that, or if the patient is septic, if the leg has a superimposed bacterial infection, if the patient is anyway bedbound, if the patient is not fit enough to undergo any surgery, you can even go for a primary amputation. So those are the three basic management principles when it comes to critical limb ischemia. Okay, but for all patients, no matter which stage they are presenting in, you have to do the risk factor modification and the cardiac assessment. Understood?
Yes, sir.
Okay. So now for this, you understand the answer, why the answer is exercise therapy and risk factor modification. Immediate bypass, definitely you will not do. Before doing a bypass or an endovascular angioplasty, you definitely need to image the patient. Again, you have to do either a DSA, digital subtraction angiogram, or a CT angiogram. Primary amputation, there is no indication mentioned in this. Thrombolysis usually not done for arterial things. It is usually done for venous disorders, but there is a place for thrombolysis in acute limb ischemia. Okay, now we're talking about chronic limb ischemia and acute limb ischemia. There is a place for thrombolysis. Okay, Hirunya, we do the next one. 72-year-old man has a pulsatile epigastric mass. Ultrasound shows an abdominal aortic aneurysm measuring 6.3 centimeters. He's otherwise fit. What is the best management?
So for this one, I went with the elimination method for the answers. So firstly, CT colon no treatment, and observation and repeat scan I eliminated at first. And then from between B and C, because the abdominal aortic aneurysm is measuring 6.3, it is rather a bigger aneurysm. So it has a risk for rupture, because if we do the open aneurysm repair, therefore I went with EVAR option B, because the man he's an older individual, and he's also the stem also mentions that he's fit. Therefore, I chose the option B.
Okay, so your answer is correct. The reasoning we need to sort of optimize a little bit more. So when it comes to triple A's, abdominal aortic aneurysms, there are two ways which they can present, either as emergencies or as elective in incidentally detected ultrasound scans, or in the West, there is actually a triple A screening program for males above 65 years of age. Males are more likely to get triple A's. So there is a size cutoff in triple A where you would decide to operate or observe. Okay, so in males, the typical size is 5.5 centimeters, and in females, it's 5 centimeters. So until that size has come, you can actually just observe the patient and do the ultrasound scans and see if there's an increase in the size. So until 5.5 centimeters in a male, you do not offer any elective surgical intervention. Of course, if he presents with a leaking or a ruptured aneurysm, you have to go for usually an open aneurysm repair. The acute stage, doing an endovascular repair is a bit difficult. But if the patient presents electively and the aneurysm is more than 5.5 centimeters, then you can go for either an open aneurysm repair or an endovascular aneurysm repair. So short-term outcomes in terms of hospital stay, complications, immobility, orthostatic pneumonia. So in all of that, early discharges, endovascular aneurysm repair is superior. But in long-term outcome, there is no difference. But in the short-term outcome, because it's superior, usually you can try to go for an endovascular aneurysm repair. The thing is, you can't do an endovascular aneurysm repair for all aneurysms. That's a bit too advanced for all actually, but just know that there are the aorta and the iliac arteries need to be in a certain specific shape for an endovascular repair to be done. So, open aneurysm repair you can do for any type. But for endovascular to be done, you have to basically the access is achieved with the bilateral femoral artery punctures. And then you have to deploy stents through both those punctures. So if the iliac arteries are very curvy and if they are very convoluted, then it's quite difficult to deploy the stent. So in that case, you have to go for an open aneurysm. So that's a bit too advanced for you. So, but what you all have to know is that in short-term outcomes, because endovascular aneurysm repair is superior, that's the best answer for this patient. Understood? Is it clear?
Yes.
So if they had mentioned the size and it was less than 5.5 centimeters, then your the answer would be observation and repeat scan. Okay. So is the size cutoff is what they're testing in this STEM 6.3. So it's 5.5 for male and 5 for female that you have to memorize, nothing to do. And so the best management in the elective setting is the EVA, okay, endovascular aneurysm repair. But you have to remember you can't do this for all aneurysms. Okay. Okay. So next one also, 40-year-old woman presented with varicose veins, skin pigmentation in the ankle and a healed venous ulcer. Duplex Doppler confirms the saphenofemoral junction incompetence. What is the first sign investigation for venous reflux? So what do you think?
I think this is a presentation of lipodermatosclerosis in the varicose veins.
Lipodermatosclerosis. Why do you say so?
Because there's hemosiderin deposits, like it says the skin pigmentation in the ankle.
Okay.
So I think it's the hemosiderin deposits because of the varicose veins.
Lipodermatosclerosis to happen, it needs to be a combination of the dermal changes which are caused by the result of chronic venous hypertension. So they should mention something about like a champagne bottle appearance or thickened sclerosed skin. So those types of things need to be there for us to say that it's lipodermatosclerosis. Okay, so anyway, irrelevant to that. So what's the answer that you chose?
I chose duplex Doppler for that.
Yeah, so
it's already been given in the STEM, but
yeah, that's the answer. So duplex Doppler is the answer. So whatever, basically, it's a good as a rule of thumb for whatever venous disorder. It could be varicose vein. It could be deep venous thrombosis. It could be superficial thrombophlebitis. Any of those, the answer is always, if it's a lower limb venous disorder, the first line investigation is always going to be a duplex Doppler. Okay. So a venography is very, very, very rarely, it's almost never done. So basically venography is all the same as like a digital subtraction angiography, where you inject the vein with contrast and then you take X-ray images and you look at the vein. Almost never done. MR angiography is the gold standard. It is the best investigation to visualize arteries or veins, But again, there is no indication to do it here. Sorry. CT angiogram or VCT venogram, again, no clear investigation because they have asked the first line investigation. And lymphoscintigraphy is used. When is lymphoscintigraphy used, Hirunne? Do you know when?
No, sir, I'm not sure.
Yeah. So lymphoscintigraphy is used in cases where there is chronic lymphedema and you suspect a lymphatic malformation. Because some people can congenitally be born with absent lymphatics, or they can have a degeneration of the lymphatics. So in these lymphatic disorders, lymphoscintigraphy is an investigation that we use. Okay. So for this, the answer is Doppler. But just I wanted to describe some of the other investigations also so that you all, in case they appear in a STEM, you all won't get like, it's not something you all have heard before. No? So you all won't get surprised. Okay. Okay. Jaini, maybe the next one. So,
So,
21 year
so I
old.
have a question.
Yes,
Sorry.
yes.
What is the treatment for this stem? According to the stem, what is the definitive treatment that we can do for this patient?
So varicose veins, skin pigmentation at the ankle, and a healed venous ulcer. So in case it's said an unhealed venous ulcer, you need to what you first need to do is heal the venous ulcer with strapping. Okay, 4-layer strapping. So once the venous ulcer is healed, then we can think of an intervention. So our options are we can go for saphenofemoral junction ligation and stripping. So open surgical option. You can go for ultrasound guided foam sclerotherapy. Basically, you give sodium tetradecyl sulfate into the veins to eliminate them, or you can go for your laser procedures, endovascular laser ablation. So those are the three main treatment. Three main modalities for venous reflux that are available in our country and what are usually practiced. So to select between those three, it depends on a lot of things. It depends on operator experience, whether the patient has undergone previous surgeries, whether the patient's veins are if the veins are extremely superficial, it's a bit dangerous to laser them because the heat can cause the damage to the overlying skin. So, but in general, now the first line treatment, if facilities are available, is EVLA, so laser ablation. Okay.
Okay, sir. Thank you.
In many peripheral hospitals where a laser machine is not available, still they will go for saphenofemoral ligation and stripping of the great saphenous or the short saphenous vein. Actually, no, short saphenous vein is not stripped. Only the great saphenous vein is stripped. The issue with open surgical ligation and stripping is the chance of damage to the saphenous nerve is very high. So they can have these neuropraxias, they can have these persistent pain, burning types of pain, they can have areas of anesthesia on their leg. So because of that, the complication rates in laser is very much less than open surgery. Okay. So next question, 71-year-old man presents with low urinary tract symptoms, including hesitance in nocturia, weak stream, and dribbling. On digital rectal examination, prostate is symmetrically enlarged and small. PSA is 3 nanograms per millimeter. What is the most appropriate management? So, Jayani, what do you think is the answer?
Alpha blocker therapy.
Alpha blocker therapy, no? I also agree with you. I feel that that's the best answer. So, what is the alpha blocker you usually use?
Tamsulosin.
Tamsulosin, 0.4 milligrams. No, yeah, good. So, why not TURP here?
It's refractory to medical management.
Yeah, very good. Usually, if it's refractory to medical management and if there are anyway immediately is out. You won't do a TURP immediately without even trying your medical management. So because of that option, you don't choose TURP. But in situations where the patient has, if the patient presents with multiple episodes of acute urinary retention, or if the patient has symptoms and signs of chronic high pressure retention. So the difference between acute retention and chronic high pressure retention is that this high pressure retention will cause hydronephrosis and hydroureter. So usually if the prostate is big enough to cause hydronephrosis and hydroureter, they will not respond to alpha blocker therapy. They will need a TURP. So radical prostatectomy is definitely not the answer. So radical prostatectomy is done when there's prostate cancer. Bilateral orchidectomy is also done when you're trying to do a total androgen ablation for metastatic prostatic cancer, where you want to completely remove any sources of testosterone or dihydrotestosterone. Watchful waiting is obviously no, because the patient has symptoms. So the answer for this is to go for an alpha blocker like tamsulosin. Next question also, Jayani, you do. 68-year-old man presents with lux and back pain. DRE reveals a hard, irregular prostate. PSA is elevated. What investigation confirms the diagnosis? What do you think?
Ultrasound
Guided biopsy. Yeah, good. So that is the best investigation to diagnose prostate cancer. But MRI prostate also can diagnose. Okay, it's also a diagnostic modality. But I assume they want the best investigation, so then you can go for a trust-guided biopsy. Why does this patient have back pain, Mejani? Metastasis. Metastasis there? Yeah, you're right. It's because of bone metastasis. Usually at this age group, patients with prostate cancer present with bone metastasis more than the lower tract symptoms, because actually prostate cancer will not cause a lot of lower tract symptoms. These patients will present with back pain. And then when you do a DRE, you will notice the irregular nodular prostate. And when you do the X-rays, you will notice that there are sclerotic lesions. Also, the PSA is very high. Usually, they say PSA of more than 30 is associated with definitive metastatic disease. So definitely you need to do a trust-guided biopsy to confirm. MRI prostate is also an option, but a trust-guided biopsy is better because it will give you a tissue diagnosis. PET scan is usually used to detect metastatic disease. And when you are not sure about the actual origin of the metastasis. So imagine a patient has undergone total prostatectomy and his PSA is elevated. PSA is like 50. So there is some cancer somewhere. There is some prostate cancer deposit somewhere, but you do your CT, you can't find anything in the CT. Then you can go for a PET scan. A PET scan will show you areas where there is high metabolic activity in the body. So metastatic deposit displays high metabolic activity, and so it will light up like a light bulb. It will light up on the PET scan. Bone scan is done to detect bone metastasis. So this STEM is asking which investigation is confirming the primary diagnosis. So then bone scan is not an option. So definitely not TURP. You can't do a TURP without having a proper diagnosis. Okay, so that's the reason why trust is the answer. Any questions, Jani, or is it clear? So next one, Tarak, do next two. So 26-year-old man after road traffic accident arrives unconscious. Airways gurgling with secretions. Pulse is 140, BP is 70/40, saturation 85. What is the first priority in this management? This is quite easy. What's the answer?
Secure.
Yeah, so secure. So again, principles don't forget your principles. Stick to your ATLS. A, B, C, D, E. Actually, now the latest ATLS is XABCDE. Okay, X is massive exsanguinating hemorrhage. That means if there is an external source of massive bleeding. So imagine if there is like a gunshot to the arm and your brachial arch is spurting out blood, then you want to put direct pressure, apply a tourniquet there at least, and then you manage the ABCD. Definitely in this you have, because they have mentioned about the airway issue, the airway is gurgling with secretions. So because of that, you have to definitely go with securing the airway. Insert chest drain you might need to, but that's not the priority. First priority, IV fluids comes in C, so it's after that. Fast scan is an adjunct to the fast scan is an adjunct to the primary survey. So you do that later, and intubate after CT scan. Definitely, you have to if you intubate after CT scan, you have to intubate a dead body only. So definitely you have to get control of your airway before anything else. Understand now?
Yeah.
Clear? Any questions? No, no. It's quite straightforward. So this question is a bit make an put a valid question. Like a 78-year-old falls at home, her right leg is short and external rotated and painful. Say shows a fracture the neck of femur. What is the most likely diagnosis? So it's a fracture neck of the femur. Just keep that question. So 32-year-old boxer sustains a trauma to the orbit. He complains of diplopia on upward gaze, infraorbital numbness, and inophthalmos. CT shows a fracture of the orbital flow. What is the most likely diagnosis? Taraka, what do you think?
No, I chose as the blowout fracture.
Yeah. So you can get questions from I and ENT also at about 1 or 2 SBAs at most. So my advice is always to keep those until the night before the exam just to quickly read. Don't waste a lot of time on I and ENT because it's not very high yield. Put the exam you're much better off reading the main core topics, but you have a small idea about these as well. So a blowout in a blowout fracture, when you get punched onto the face, it can cause a nerve injury to the intraorbital nerve, which is a branch of the trigeminal nerve, which is why there's intraorbital numbness. The eyeball can go in because of the depression that is produced, and you can get diplopia on upward gaze because your inferior rectus is also injured. So that is why the answer is a blowout fracture. Zygomatic arch fracture is here. Usually they will not have any ocular symptoms in a zygomatic arch fracture. In a maxillary fracture also, unless it's going up to the orbit, they will not have any inophthalmos or diplopia, but infraorbital numbness can be there in a maxillary fracture. Ethmoid fracture, they will usually present with some sort of nasal symptoms. In a skull-based fracture, they will have CSF, otorrhea, rhinorrhea, and can have raccoon eyes and battle sign, which is they can have a hemorrhage retroorbitally. So those are supposed to be there in skull-based fracture. Okay. So even though it's an eye question, it's not very hard. Don't worry. Okay, so last SBA. Hirunya, okay, you do this one. 28-year-old, it's also very easy one. 28-year-old man following a motorbike accident presents with the inability to extend the wrist and fingers. Sensation is lost over the dorsum of the hand. Which nerve is most likely injured?
The answer is C, radial nerve here, because the stem gives a picture of the wrist drop.
Yeah. One important thing is there is sensation will only be lost over the dorsal aspect of the first web space, okay? Because the rest of the dorsum of the hand is innervated by the ulnar nerve and the median nerve. The superficial radial nerve has a very specific sensory supply to the first dorsal aspect of the first web space. Others all are supplied by the ulnar and median nerves. But this is, I think that's what they have meant. So this is a very clear wrist drop. So the answer is a radial nerve palsy. Okay, so I went a bit slowly today because I wanted to go through the concepts so we can do the the true false next time. What do you think? Any suggestions or any advice regarding how best to conduct this? What you all feel? Was it useful first of all?
Yes, sir, this is definitely useful. Thank you.
Was
Yeah,
it
very
too
good.
fast or anything? What do you all feel?
No, I think the pace is good. This is okay because like we need to also discuss why we eliminate some of the
Yeah,
answers. So
exactly.
it's good.
And I spent a bit more time on this peripheral vascular disease, some of the basic principles of management, because actually surgery is very simple. These main core topics are very simple. So if you get those concepts down, it's going to help you not only in the theory, but it's going to make your life in the OSCE also very easy. So it's always good to get concepts stick with you have to always nail those concepts. So that's what we're trying to do. I think from next time onwards, I will do this MCQ and we'll start a new paper as well. Be a bit more fast, but if you all have any areas where you all need to focus on more, you can definitely tell me. I like the fact that everyone spoke very well. It's always good. You always have to speak and get used to defending and backing up your points, because in the OSCEs and the Vivas, the examiners will attack you sometimes. So you need to be calm, and you need to know how to handle that. The first thing, so the first step to that is definitely being able to speak in class. So Jayani, you need to speak a little bit more. Your knowledge is very good. Most of the answers you gave were correct, but you need to speak a bit more. Don't be scared, man. You have to develop that speaking ability, now itself. Because getting through the theory is a challenge, but getting through the Viva is also another challenge. So you need to think about that. I think from the next time onwards, it's going to be the paid classes. We'll have a WhatsApp group as well for all the people who are going to join. And any SBAs or questions that you all come across, you all can, or any general questions that you all have with regard to surgery, you all can actually message on that WhatsApp group, and I will reply to them. So it needs to be a
Okay,
very
sir. Thank you.
interactive session. Because when you all are going for the exam, you all need to be crystal clear on most of the concepts. Because if your
Okay,
concepts
sir.
are clear, everyone can study and get the fine points. But if your once the concepts are clear, you can answer basically any SBA. And because a lot
Yeah,
of questions are there on
I
ATLS
actually
and
figured that
yeah.
some of the answers that I chose, looking at the STEM, were quite superficial
Yeah.
because my concepts were quite lacking.
Yeah.
And
But
I'm
you
not
can.
attending any surgery classes as such. So for this
Okay.
exam, I'm doing on my own.
Okay. So just going through the paper sessions, you can get a lot of knowledge. And one thing I want this to be is, just tell your friends also, it needs to be, I want this to be an interactive set. I don't want to just be talking and then everyone's just listening and then everyone is scared to ask questions, because because I was also once in your same shoes. I was also a ERPM student. Then I got through the first time, and then I did my postgraduate. I got through that also the first time. I did my MRCS exams recently, finished those also. So I was in the exact same shoes as you guys were at this point, and I knew the things that I lacked back then. I wish I could speak to to my teachers and the lecturers who did the classes and have more interactive sessions, but we weren't given that chance. So I want you guys to definitely have that chance to be able to clarify all of your doubts and to always know why this is the right answer and why the others are the wrong answers, and when to select those answers. So those are the things that need to be drilled into your head. Once we, of course, find a few paper classes, I will go into more detail about how exactly to analyze a SBA. As in, sometimes when you don't know the answer at all, then you need to properly read the SBA and eliminate according to that. But before doing that, you need to get your concepts and basic knowledge down. So we'll talk about those exam strategies later. But until now, I think you guys are also good, great. May all have read and done the paper also. I'm very happy with you guys. May definitely
Thank you,
you
sir.
all will have no problems may passing. Just be consistent and don't be too lax on any subject. And now the thing is, now surgery and gyn obs are combined. So usually gyn obs, even when I was doing ERPM, it has been consistent. The gyn obs paper is quite hard. It's quite difficult. So since it's combined, you have an extremely good chance of passing if you can nail these surgery answers, because I don't think the questions are very difficult. I mean, if your concepts are true, you can definitely get at least 21 to 22 SBAs out of 25. And if you do that, then the pressure that you get from the GNOBS component is much less. So you can compensate with surgery. So I think that's a big advantage this time. So if you can score well in your surgery component, then even because GNOBS concepts can be very confusing as well. So because of that, you can compensate and you can get through, because so many people fail GNOBS in our time and the times afterwards as well. So, and if you focus well on theory, if you focus on those concepts, when you answering in a Viva or an OSCE is going to be very easy. So that's why. Okay, then. All right. Thank you guys for attending. I hope we see you guys
Okay,
soon.
sir.
Okay. Good night.
Okay,
Thank you,
thank
sir.
you.
Good night.
Yeah,
Thank you.
good night. Good night.